Hi, everyone. Welcome. We'll get started in just a minute. There's just people are trickling in, and we'll get started in 1 minute. Thank you for being here. Okay, thank you everyone for joining us for our Informatics and Implementation Science Learning Series. This is a joint effort between Advanced CTR, Rhode Island Quality Institute, the Implementation Science Core of the Brown Department of Psychiatry and Human Behavior, and the Brown Center for Biomedical Informatics. My name is Ronnie Elwey. I'm the director of the Implementation Science Core in Psychiatry, and we're really happy to and very excited to welcome Dr. Timothy Hogan to join us today. He's going to be talking about engaging patients through technology, advancing the intersection of consumer health informatics and implementation science. Dr. Hogan is an associate professor in the Department of Population and Data Sciences and joined the faculty of University of Southwestern, University of Texas and Southwestern in Dallas back in 2019. He is also the director of the Department of Veterans Affairs eHealth Partnered Evaluation Initiative and a research health scientist with the VA Center for Healthcare Organization and Implementation Research. This is one of 18 centers of innovation across the country that is funded by the VA and is a really exciting place because Tim and I work there, and there's a lot of great eHealth work that's coming out of our program there in collaboration with the Office of Connected Care. Dr. Hogan completed a VA postdoc in health services research. He earned a PhD and an MS in library and information sciences from the University of Illinois at Urbana-Champaign, and as well as a BS in information science from the University of Pittsburgh. Prior to joining UTSouthwestern, he was an associate professor in the Division of Health Informatics and Implementation Science within the Department of Population and Quantitative Health Sciences at the University of Massachusetts Medical School. On a personal note, I've known Dr. Hogan for over 10 years. I've been so impressed with his work combining both informatics and implementation science. This is truly a rare thing that occurs in our field, and I can't wait for him to share his work. He's been a funded PI on multiple projects, both on the NIH and VA side, and we're really looking forward to having him here. So welcome so much, Dr. Hogan.
So thank you so much for that, Ronnie, and thanks to everyone for joining today. I'm really excited to be here. As Ronnie said, it's an interesting niche working in informatics and implementation science, and I've been hearing from Ronnie about the interest of this group and just how excited she's been about the conversations that you all are having about informatics and implementation science. So it means a lot to be invited to come here, and I really appreciate the opportunity to tell you a little bit about some of the virtual care work we're doing in the VA. This is just my support and disclaimer slide. And what I'd like to do is just go over some of the goals for today. So first, I do want to spend some time just talking about the significance of virtual care for not just the VA, but healthcare systems in general, and what I mean by this term virtual care. And then we're going to focus in on some groundbreaking virtual care initiatives in the Department of Veterans Affairs. And I'd like to try to also do some kind of framing and maybe reframing around some key methodological issues and implementation issues when we're thinking about virtual care technologies, again, not just in the VA, but also across other kinds of other healthcare organizations. Then I'd like to spend some time sharing with you two virtual care implementation projects that we have pursued as part of the eHealth Partnered Evaluation Initiative that Ronnie mentioned. And I've tried to structure the talk so that we have enough time at the end to discuss the interest that you all may have in virtual care implementation. So I'm hoping we have some time to do that as well. So before we get too far into things, when I give talks like this, I sometimes like to share this tire swing cartoon, and I'm not sure if folks in the group have seen this before, but I like this cartoon because it really shows the kind of varied perspectives that are at play when we're thinking about implementing a virtual care technology, and the complexity that introduces into the process of implementation. And you kind of see this here that, we have all of these different conceptualizations of this swing, but what the user really wanted was a simple tire swing, right? So we're going to come back to this idea of the different perspectives that stakeholders can have in the course of implementing virtual care. So something to keep in mind. And I also want to, kind of further set the scene here and just talk for a minute about patient engagement as a lens through which we can think about some of the topics we're going to talk about today. So, I think it's probably not surprising to folks in this group. Patient engagement has emerged as a key value in our healthcare system. We talk a lot about this paradigm of patient engagement. Patient engagement is a blockbuster drug, and so on. And patient-facing virtual care technologies, so technologies that are designed for and intended to be used by patients, have a role to play in patient engagement, right? They're supposed to support and facilitate patient engagement. But what we've seen and what sort of the evidence has bore out, across healthcare systems is that adoption of these technologies can be slow and also uneven across different patient groups. So again, we're going to keep this idea of patient engagement in mind as we go through the talk today. So let me tell you a little bit, just real briefly, about me and the perspective I bring to virtual care implementation work. So I am, as Ronnie said, an information scientist by training. As an information scientist, you're taught that all human activities, whether you're talking about individual level activities or activities of an organization, involve some kind of production, construction, or use of information. We oftentimes talk about the delivery of healthcare as an information-based science, right? We can't deliver healthcare without handling, interacting with, and using, all kinds of different information. In addition to that perspective, I found it very helpful over the years to leverage sociological and nursing concepts in my work. So people on my team oftentimes hear me talk about this idea of trajectories that represent patterns of disease over time, but not just patterns of disease, again, returning to this information science lens, thinking about patterns of information use, right, and technology use over a patient's care trajectory. Methodologically, I'm trained as a field researcher. I use a lot of qualitative methods, a lot of mixed methods in my work. And certainly, again, probably like a lot of you on this call, value interdisciplinarity and team science. So let's talk about what virtual care is all about. I've tossed this word around a few times now. And I'd like to share, this is sort of my kind of the definition of the term that I like. So virtual care is a model of care focused on improving healthcare through technology that engages patients, their families, and clinical teams beyond episodic traditional in-person visits. And that definition really kind of reflects calls by major medical organizations like the Institute of Medicine, which for years has been advocating for this shift away from episodic healthcare to more continuous healthcare, right? When we talk about virtual care, again, I really want you all to think about patient-facing technologies, again, technologies designed for and intended to be used by patients, as much as clinical team-facing technologies, right? Which is, I think, what we oftentimes think about when we think about technology in healthcare, right? We think about the EMR. So we need to think a little bit more broadly than that. And then lastly, thinking about augmentation as opposed to replacement, right? So I don't see these kinds of technologies as a replacement for high quality in-person care, but as a way to augment that care, to extend that care, to improve on that care. And for folks who are informatics readers, I put this graphic from Friedman's, very famous article, which shows that, a human brain plus some technology is greater than just the human brain alone, right? So it's kind of augmentation in an equation. So I find that, I don't want to make a lot of assumptions about folks' familiarity with the VA as a healthcare system. So I do want to give you just some quick context about the VA, which I think will help as we step through the couple of projects I want to go over today. So the VA is the nation's largest integrated healthcare system. We have over 9 million veterans who are enrolled in the system. And at any given time, we have over 6 million veterans who are receiving services through us. We have over 325,000 employees in the healthcare system. We have over 1,200 sites of care. And again, probably as you know, the VA has a long and pretty illustrious history of using health information technology in innovative ways to deliver care. As a population, the veterans who receive care through the VA tend to be geographically dispersed. So they live in highly urban areas, they live in highly rural areas. They also tend to be users of multiple healthcare systems. So that's particularly the case now with more recent policy that has been passed, advocating and providing new avenues for veterans to get care out in the community. Veterans are also faced on average with more socioeconomic challenges than the general population. And they are also sometimes managing unique healthcare needs related to their military service. And they also tend to have a higher burden of comorbid chronic conditions than the general population. Also, like other healthcare systems right now around the world, and certainly in the US, the VA is facing an unprecedented growth in the number of virtual care technologies that are being rolled out and to which patients have access. So I was happy I could include this slide, and I'll say this is sort of hot off the press. So you heard it here first. This is a snapshot from the Office of Connected Care's strategic plan. Ronnie mentioned the Office of Connected Care in her opening remarks. This office is the office in VA that's responsible for the system's digital health strategy. And what I have here are the three sort of overarching goals that were released as part of their new strategic plan just within the last couple of weeks. And so I wanted to be sure to share this with the group. So their first goal is to enhance veteran digital engagement with the healthcare system. The VA is committed to doing this by revamping and building an engaging digital front door, sort of a virtual front door through which all veterans will pass to access services from the healthcare system. Supporting veteran self-management has been a long-term goal of these technologies. They want to continue that commitment. Second, to deliver healthcare to veterans, without walls. There's a big focus here on delivery of care into the home through new technologies that the VA is rolling out, but also then expanding the VA's clinical capacity and expanding the VA workforce's confidence to offer care in this manner. So making the switch from in-person visits to virtual visits, clinicians were forced to have to do this in the period of COVID over the last year, but it's not an easy thing to do. So thinking about how we build those competencies and those capacities into our workforce. And then lastly, solidifying connected care foundation. So, continuing to modernize the VA's technical infrastructure to be able to have these kinds of technologies and have them function well and seamlessly. And then also to build out, analytic capabilities to be able to analyze and work with the kinds of new digital health data that are going to be coming available in the healthcare system in the years ahead. And we'll touch on this just a little bit later in the talk when I mention the role of patient-generated health data. So I keep, talking about sort of the range of virtual care technologies that are out there, and I use this slide to kind of provide a shorthand, kind of 4 big buckets of these virtual care technologies in the VA. And so hopefully this will be a helpful shorthand for all of you as well. So first, at the top here, the VA has a personal health record portal. It's called mhealth. It's a tethered online patient portal that offers a suite of tools to support communication, information access, transactions with the healthcare system. Moving over to the left, the VA also has an expanding portfolio of mobile health applications for both veterans and clinical team members. Many of those apps have been developed through public-private partnerships. We're going to talk a lot about the automated texting system today and one of the projects I'm going to review. The VA also has a robust telehealth services portfolio. Our telehealth services includes various modalities, video visits being probably the most prominent that folks think about. Video visits include those across clinics and sites of care, as well as into veterans' homes, remote monitoring capabilities, as well as asynchronous store and forward capabilities. And then lastly, I'd like to mention VA's innovation program. So VA has this really exciting innovations program that encourages stakeholders and frontline healthcare providers to submit ideas for healthcare system improvement. And what we see is that a lot of those ideas involve using new and different kinds of technology. So we see a big focus on technology there as well. So hopefully that's a helpful shorthand for folks. And this is sort of my timeline slide, and I always qualify this by saying this timeline is not to scale, but it gives you just a rough sense of the rollout of these different technologies in the VA. So our synchronous and asynchronous telehealth capacities have been around the longest. Our patient portal kind of came on the scene in the early 2000s. The secure messaging feature of the portal, which I would call kind of the killer feature, it's kind of the most used, is maybe the second most used feature, but I think it's what drove a lot of adoption of the portal, was released, I think in 2008, 2009, it started to be rolled out. More recently then, we've had the mobile apps rolling out, and the focus on VA Video Connect and automated texting. In terms of facts and figures, so our patient portal, mhealth, we have over 5.7 million registered users. Some impressive statistics here: over 180 million VA prescription refills have been completed through the portal since 2005. We've exchanged over 122 million secure messages since 2008. Our first telehealth episode dates back to 1959. I believe it was a remote group visit for mental health. Don't quote me on that. I can check that. I can confirm that if folks are interested. And, this is a not surprising statistic that, since March of last year with the COVID pandemic, we had over 1,000% increase in the number of video visits that we were doing with veterans. In terms of our mobile app portfolio, we have over 30 apps that are really intended for use by veterans. We have over 10 apps for clinicians. And we have this exciting automated texting system that was actually developed through an international collaboration with the National Health Service in the UK, and we're going to talk about that as well. I'm not going to spend a lot of time on these next couple of slides, but I do think it's helpful just to give you a sense of the VA's journey in terms of building capacity for research and quality improvement work around virtual care technologies. So I joined the VA back in, I would say, 2007. And around that time, you saw a lot of investigators that were doing research projects related to virtual care, but they really weren't organized in any way. It was sort of just, kind of groups of folks around the country. Around 2009, when the portal started taking off, we saw more proposals being written that were focused on the patient portal. And as adoption of the portal expanded, many researchers, myself included, began forming relationships with leadership in the Office of Connected Care. Again, that's the office responsible for the VA's digital health strategy, as well as other offices and other points of leadership to try to broaden the research and evaluation agenda around VA's patient portal. So we published research agendas. We started thinking about processes and infrastructure needed to support more research and evaluation work focused on the portal, and started forming work groups that could address questions about measurement, metrics, data sources, and so on. More recently then, what we started to see were groups and centers starting to be established that were focused on virtual care. So in 2011, there was an eHealth Quality Enhancement Research Initiative Center stood up. That center was renewed as the eHealth Partnered Evaluation Initiative in 2015. This is the center that I lead, and we've been continuously funded since that time. But in addition, there's a great group of researchers that came on the scene in 2015, led by John Fortney. Some folks may know his name, great virtual care researcher, and he leads the virtual care specialty query program out in Seattle. Just even more recently, we've launched the Virtual Care Consortium of Research, which is intended to help build additional infrastructure to speed the research cycle around virtual care so we can start to realize impacts of these technologies in the course of clinical care more quickly. And of course, we continue to have this robust portfolio of individual investigators who are writing the NIH equivalent of R01s in the VA and conducting research projects. So it's really been a busy time and just a lot of growth in the area of virtual care. So before we dive into these couple of projects of our eHealth PEI, I want to just give you some of the overarching objectives of the eHealth Partnered Evaluation Initiative. So first, our center aims to demonstrate the impact of VA patient-facing technologies on outcomes important to patients in the healthcare system. And second, to identify fruitful strategies to further the adoption of patient-facing technologies among patients and clinical team members. And I think you'll see these objectives kind of woven through these couple of studies that these couple of projects that I'm going to present to you today. The work we do as part of the eHealth Partnered Evaluation Initiative is designated as quality improvement. That designation reflects the partnership that we have with operations and clinical leadership in the VA, as well as the funding sources for the work. And I'm not going to go through all of this. I include this slide, and I want everybody to have this in case you're interested after the talk or you want to follow up about some of the other work that we've done. We've really studied various technology platforms over the years, ranging from the secure messaging feature of our patient portal to the automated texting system, which I'm going to talk about today, and more recently, some of the VA's mobile apps. And I have some of our papers just kind of, highlighted here on the slide, but do let me know if you're interested in hearing more about any of this work. So we're about to dive into a couple of these projects now. And what I'd like to do is further set the scene a little bit and plant some seeds that maybe will spark some discussion later about issues in implementing and evaluating virtual care technologies. And I don't know, when I share these questions, I think sometimes people see these as kind of perplexing questions. Some people might call these wicked problems, but things to think about as we go through the next 40 minutes or so, together. So how can we address the needs for both effectiveness data and implementation insights, when we're studying virtual care? What implementation strategies work when and where for different kinds of virtual care technologies? What outcomes should be our focus? What frameworks and models should guide our work? And how do we understand the potential unintended consequences of these technologies? So things to think about. So let's dive into our first project. This project is called Automated Text Messaging with Patients in VA Specialty Clinics, a Hybrid Type 2 Effectiveness Implementation Study. This study, the PI for this project was Keith McGinnis. He's did a great job, led a great team. I have some of our team members highlighted here on this slide. And I know this group is in good hands with Dr. Alwi. I am sure she has talked to everybody about hybrid designs, but I did want to include this slide just to make sure we were all on the same page. So when we talk about hybrid designs in implementation science, right, we're talking about studies that include some balancing of a focus on effectiveness and implementation in an effort to speed the research cycle, right? And hybrid type 2 studies take as their focus both testing and implementation strategy, but also testing an intervention, right? And so in this case, we were interested in testing our strategy and implementation strategy, as well as testing our clinical intervention, which was the VA's automated texting system. So a little bit of background about the texting system. I mentioned this earlier. So the texting system is grounded in a substantial body of work focused on automated tailored health messaging systems. That literature has been growing over the past 30 years or so. It is a protocol-driven system, so protocols are written. The protocols are essentially a series of rules for the delivery and exchange of text messages. And then those messages are delivered according to the protocol. They can be one-way messages or two-way messages with feedback given to patients. And typically, the messages can have different kinds of content, but they oftentimes address different self-management tasks that patients face. So keeping appointments, keeping up with your medications. But in addition to focusing on those kinds of tasks, sharing tips, right? Sharing motivational messages with patients. In terms of the intended benefits of the system for patients, the vision of the system was that it would offer easy access to patients on their personal phone. There's no special usernames or passwords required. Hopefully it would promote engagement in patients' care plans. So again, returning to that idea of patient engagement. And in terms of benefits for clinicians, this is really a self-management system. So there's no requirement for clinicians to send or read these text messages. And veterans are told that at the point they sign up to use the system. But there's certainly potential for the system to augment and support the care plans that clinicians develop with their patients, right? So going back to that idea of augmentation. So let me tell you a little bit about the hepatitis C protocol that we developed for this study. So we chose to focus this project in the context of hepatitis C. We did so because Hep C treatment involves a time-limited predefined course of daily medication that requires really careful adherence as well as follow-up laboratory work. So it seemed like it was a great context in which to test out the VA's texting system. The protocol that we designed included medication reminders, lab reminders for patients, appointment reminders, as well as motivational messages to remind them about the progress they were making through their Hep C treatment and to encourage them to complete it. We created the protocol in consultation with Hep C clinical experts, and they were great in terms of giving us feedback on the clinical appropriateness of the protocol, as well as making sure it was would be meaningful to their patients. So the objective of this project was to evaluate the implementation and effectiveness of the automated texting system across specialty care Hep C clinics and to test an automated implementation strategy to facilitate more rapid adoption of the texting system, right? So very much in line with a hybrid type 2 trial. In terms of our methods, hepatitis C clinics were recruited through a national listserv and through a monthly national Hep C clinic conference call. We purposefully selected 7 clinics that expressed interest in the project based on a series of criteria, including their clinic size, complexity, and where they were located geographically. And these 7 clinics were then randomized to one of 2 implementation strategies, either usual facilitation implementation or augmented facilitation implementation. And you can see here that our usual facilitation included training and resources from the texting system development team within the VA, calls with our evaluation team to tailor the Hep C protocol to their local clinic workflows, as well as the availability of an external facilitator to consult if they had any questions or they needed to troubleshoot. In contrast, the augmented facilitation implementation clinics had those same training and resources from the texting system developers. They could have calls with our team to tailor the protocol to their local working conditions. But different from the usual facilitation clinics, they had proactive outreach by an external facilitator. And they also worked with the external facilitator to identify and prepare local clinical champions who would advocate for the texting system locally. And those clinical champions were given a toolkit to sort of aid them in that work. To help us determine the effectiveness of the texting system, we also had 2 additional matched comparison sites that we had identified, and they had similar clinics in terms of size, complexity, and geographic locale. So in terms of our measures, we gathered a variety of qualitative and quantitative data to understand the implementation and effectiveness of the texting system. So in the way of implementation process measures, we gathered baseline organizational survey data, follow-up survey data, activity logs, and we conducted follow-up semi-structured interviews with healthcare providers. We collected baseline follow-up survey and conducted semi-structured interviews with patients. We also asked our external facilitator to keep an activity log so we could track the implementation activities that she was engaging in. And in terms of our outcomes, we gathered data on what we called the texting system initiation cascade. And these were really the steps involved for a patient to begin using the texting system. So first step in using the texting system was that a provider needed to offer the texting system to a patient. Second, the provider needed to register the patient and assign them our hepatitis C protocol that we created. The third step, patients needed to authenticate their phone number with the texting system. And then fourth, patients needed to start to receive and respond to the text messages. And then finally, we collected some measures related to Hep C. Patient self-reports of treatment distress, medication adherence, and we looked at sustained virologic response to Hep C. So in terms of results across all of our Hep C clinics, responses to baseline provider surveys indicated that provider characteristics were balanced on key factors, age, sex, technology, experience. And our care teams across the clinics consisted of a range of different types of providers. So pharmacists, nurse practitioners, registered nurses, social workers. And across the clinics in our usual and augmented implementation arms, responses to baseline provider surveys indicated that there weren't significant differences across the clinics on readiness to implement the texting system, perceptions of the strength of evidence for texting in healthcare, or even their local implementation climates. So pretty balanced on these factors. So this slide, if there's one I want you to remember about this project, this is it. It probably conveys the most important take-home message from this project. And it's a tough message when we think back to, how much effort was put into designing and thinking through our implementation strategy. But what this slide shows is the number of patients who made it through each of the 4 steps of that initiation cascade that I mentioned earlier. So what you see here is that across the 7 clinics that received the texting system, there were a total of 625 patients that started Hep C treatment during our implementation period. But what you see is this steep drop, right? There's a steep drop in terms of the number of patients who made it through each of the subsequent steps of that initiation cascade. So we had 197 patients of our 625 who were offered the texting system by their providers. 71 patients were actually registered and assigned the Hep C protocol. 50 patients authenticated their phone numbers with the texting system, and 32 patients actually responded to at least one message that they received from the Hep C protocol. When we look at the steps in the initiation cascade, just by implementation arm, we see a somewhat different story. And what this table shows is the number of patients who were retained from one step in that cascade, in that initiation cascade, to the next by usual and augmented implementation. And what we see here is that patients at the augmented implementation sites seem to make it, further through to that, at least the last step in the initiation cascade. So step 4, we had more patients that responded at augmented implementation sites to the protocol messages than at the usual implementation sites. So how about our external facilitation work, our data on implementation facilitation? Well, over the 10-month implementation period, there was a total of 293 facilitation events that were logged, with a mean number of 42 facilitation events per site. We didn't see any significant differences in the number of facilitation events between the augmented and usual implementation sites. This was a little curious to us. And one of the explanations that we think might hold to help explain this finding is that, at the augmented implementation sites, the communication between the external facilitator and the champions was much more focused. And because of that, that probably meant that there was maybe less redundant information sharing and troubleshooting. So just sort of one hypothesis for this, what we thought was very interesting finding about our external facilitation. So in terms of some more results, so this was an interesting findings from our providers at the augmented implementation and usual implementation sites, who expressed a fair amount of surprise about the high number of patients who essentially said thanks but no thanks when they were offered the texting system to help with their Hep C treatment. And this is just a quote from a provider here. So quote, "I thought a lot of people were going to be able to participate, but I guess when we started offering, some patients don't. I guess they're not used to it. Most of the patients that I offered it declined to participate." And what we saw was that reasons for declination kind of fell into 4 main categories. There was, in most cases, just general patient disinterest. There was expressed inability to text, or texting was perceived as being cost prohibitive. There was a perception by some patients that they already felt that they were already pretty good at adherence and maybe they didn't need this technology. And then some had a belief that the texting would be sort of duplicative with other self-management techniques that they were already using. So important reasons to reflect on as we think about ways to promote adoption. So in terms of perceived usability, ease of use of the texting system among patients who made it fully through that initiation cascade and started sending and receiving text messages, perceived the usability and ease of the use of the system as pretty high. And our semi-structured interviews revealed some more nuanced insights around usability issues and ease of use. The quote on this slide is from a patient describing the challenges grasping that the texting system was not a real person. It was not somebody from their care team that they were texting with. And so, quote, "Understanding that the texting system wasn't a real person, that I had to wait for the texting system to contact me before I could contact it, was something that was a little bit confusing for some of the patients." In terms of perceived usefulness, again, among patients who made it fully through the texting initiation cascade and started using the system, sending and receiving messages, there was pretty much universal endorsement of the usefulness of the system. And this is just another quote from a patient. So, quote, "I use the texting system for other medications as well. I group them all in together." So this was something we thought that was a little interesting, sort of spillover effect. So the protocol was focused on Hep C treatment, but there were patients who had described using the texting system to remind them about all of their different medications they were taking. And then lastly, in terms of perceived usability and usefulness among providers at the augmented and usual implementation sites, what this slide shows is that the texting system was perceived positively by providers. Many intended to keep using it, but that they also had some trouble ramping up and getting started with the system, and that there was certainly a perception among some that it added a lot of work to their day. So this quote from a provider, "I still think it's a challenge for me to make time in my clinic visits to have to pitch this and then set it up." And then lastly, in terms of effectiveness outcomes, patients who made it through the initiation cascade and texted reported lower distress about failing their Hep C treatments and better adherence to their medications compared to non-texters. We didn't see any significant differences in clinical effectiveness outcomes between patients based on their use of the texting system. Really no difference in sustained virologic response among texters and non-texters. So this is a lot. There's a lot of data here. I think it's helpful to just kind of pause for a minute and take stock. What do we make of all this? This is maybe some take-home points or food for thought. So the texting system was largely deemed acceptable and useful by patients and providers that we interviewed at the end of this study. We didn't see significant differences in the number of facilitation events between our augmented and usual implementation sites. I offered a possible explanation about why that may be. Our augmented implementation may have helped some patients make it further through the latter steps of that initiation cascade. But the bottom line is we still see this tremendous drop off right across the steps needed to initiate use. We feel pretty confident that future implementation strategies need to test other types of approaches to enrollment in the texting system. So is self-enrollment a possibility? Thinking about prescriptions for the texting system as another way to help facilitate enrollment. And yet, finally, I think this is the encouraging point, right? That despite the low yield, when you look at some of these findings at scale, I think they do suggest that the texting system could reach and potentially impact many patients. So is there potential for supporting kind of long-term effectiveness here and maybe spillover effects? So realizing impacts of the texting system that maybe we didn't even anticipate in the case of supporting medication adherence for other medications beyond Hep C, as some of our patient participants told us. So I'm going to keep moving through here. And so in the interest of time, I'm going to go quickly through this next project. I actually have considerably fewer slides on this project, but I think it's a really important initiative we're pursuing, and I did want to bring it to you all today. So this second project is called the Veteran Engagement with Technology Collaborative Cohort. This work is ongoing. And what I'd like to do is just give you a little bit of rationale for this project, again, which I think reflects many of the themes that we've already been discussing today. So first, as I think I've tried to convey, so promoting adoption of these virtual care technologies is difficult in the VA and across other healthcare systems, and integrating them into care can be elusive. Increasing work is focusing on bolstering adoption of these technologies across healthcare systems and monitoring their impacts. But this kind of work is also challenging. And if you've done any of this work, you've probably encountered a couple of these challenges that I have noted here on the slide. So first, this persistent mismatch that exists between research or evaluation timelines and technology development cycles. This problem that the technologies that we are oftentimes moving to implement and to evaluate are changing and evolving underneath our feet. In some cases, they may even be sunsetting while a project is ongoing. So this mismatch in timelines. Also then this idea of missing data. So healthcare systems, including the VA, doesn't typically have a lot of data on hand related to covariates that might speak to technology use, patient-related outcomes that may also be patient-reported outcomes that might be related to technology use, and so on. And when we reflected on some of these challenges, it really suggested to us the need to think about developing more infrastructure to support virtual care research and evaluation. So building on these ideas, in 2016, VA leadership from the Office of Connected Care, again, that's our office that's responsible for our digital health strategy, um, uh, we got together with this leadership and we started to talk about how we could begin to develop this kind of infrastructure. And would emerge from those conversations more plans to recruit a cohort of veterans, purposefully sampled, who would be willing to make a long-term commitment to providing feedback about the latest VA patient-facing technologies that are rolling out, and helping VA understand how best to implement them and their potential benefits. Our team was funded to recruit and retain that cohort of veterans, to manage that cohort, and then to analyze the data that we collect from them. So recruitment for this cohort began in 2017. We collected data from 14 medical centers across the US. Those medical centers were selected based on their different geographic locations, the patient populations they serve, their history of adopting different virtual care technologies. And for patients to be eligible to be in the cohort, they needed to be 18 years of age or older. They needed to have used VA services in the last year. They needed to own a cell phone. And we also wanted to identify veterans who were established technology users, right? Given the goals of the cohort, that seemed like an important criterion for inclusion. And so we used secure messaging use as a marker for technology adoption. So veterans needed to have sent at least 5 secure messages in the last year to be eligible for inclusion in the cohort. Data has been collected from the cohort through telephone administered surveys. We merged that data with administrative data from VA's corporate data warehouse. To date, we have had 2,727 patients completed a baseline survey for the cohort. And we fielded a follow-up survey of which 1,406 veterans completed. And we currently have plans underway for a 3rd survey this year. I'm not going to go through all of this description about the cohort. It's here for you if you're interested. I'm happy to answer questions in the end about it. I will say one thing we do with our cohort is an extensive marketing and outreach campaign. The marketing and outreach campaign really draws on lessons learned from some of our previous evaluation work. And we use a strategy in our outreach program to remind veterans that they are part of this VETC cohort, to promote a sense of membership in the cohort, and then to use these newsletters, outreach materials, fact sheets, and so on to educate members about the latest VA technologies that are rolling out and encouraging them to try them out. Our observational analyses with the cohort are ongoing. I just had a couple interesting preliminary findings here that I wanted to share. So, at the request of leadership, we're really focused on looking at different patient factors that might be associated with adoption of different VA virtual care technologies, and also the role that VA healthcare team members can play in adopting these different technologies. And some preliminary findings that I think really speak to novel and important ideas for the development of future implementation strategies. So first, in an analysis we're completing right now, we found that veterans who reported that their healthcare team members encouraged them to use VA mobile health apps were also more likely to self-report use of those apps. And in a related analysis, we've also identified various factors associated with veterans self-reporting that their healthcare team members encourage them to use the secure messaging feature of VA's patient portal. Some of those factors that have been significant so far in our analyses include being an early adopter of technology, a self-reported early adopter, being of higher socioeconomic status, and being of self-reported better overall health. Again, so those were factors identified as associated with being encouraged to use secure messaging. Raises interesting questions about potential for disparities and, again, the role of healthcare team member encouragement as an implementation strategy. So implications and next steps, we're going to continue to use the VETC cohort to understand not only potential impacts of the virtual care technologies that the VA is rolling out, but also to think about how we can glean insights from this cohort of veterans who have generously given of their time and made this commitment to their healthcare system to help us think about the components of multi-component implementation strategies that might help other veterans adopt and use the virtual care technologies that the healthcare system is rolling out. Plans are underway to evaluate patient experiences with and perceptions of patient-generated health data and its integration into care through the VETC cohort. Patient-generated health data is going to be the next big thing, I think, if I'm reading the tea leaves for VA's virtual care program. I'm happy to talk with a group about that if that's something we're interested in. Again, VA is really reflecting on the infrastructure, the analytic infrastructure needed to be able to work with and make sense of and mine the patient-generated health data that is going to be gathered from the different types of devices that veterans are using and that are submitting and sending data, transmitting data back to the VA. We have a continued commitment to keep resurveying this cohort over time. As I told you, we have another survey that's in the works now for this fiscal year. So that really brings me to the end here. So what I want to do is sort of just leave the group with some big picture questions, thoughts that tie to not just these two projects, but hopefully maybe work that you're all pursuing as well. So I think our experiences in the VA and certainly from these projects that I've shared, I think we've realized that the search to identify and test implementation strategies for different virtual care technologies or technology-assisted interventions really needs to continue. A lot of patients do not seem to be aware of the portfolio of technologies that are available in VA. I think that's probably the case across other healthcare systems. We've got to do a better job finding ways to engage patients with these technologies. We also have to find a way to demonstrate their value to healthcare providers. This emerging finding around the importance of healthcare provider encouragement also seems very significant to us in thinking about the role that healthcare provider encouragement plays in patient adoption of these technologies. We are trying to think more and more creatively about family systems approaches to supporting implementation. So maybe a patient doesn't feel very confident in their ability to use an app, but their spouse or their child might. And so how can we think about involving the family or loved ones or even friends and neighbors as part of implementation strategies? User-centered design and participatory approaches to help inform implementation strategies that we might be using. And then, you know, again, I'm imagining that there are folks in this audience who have thought about this issue that, you know, in the literature, we really have two distinct and kind of disconnected literatures right now that could inform virtual care implementation. We have a whole literature around health information technology in the implementation and evaluation of HIT. And then we have the whole implementation science literature with its frameworks and methods and implementation strategies. And there's really not a lot of literature thinking that has been done at the intersection of those two literatures. And I think that's kind of a missed opportunity that might help us think more creatively about implementation strategies. Further work is needed to understand the types of patients that are most likely to benefit from different virtual care technologies or technology-assisted interventions. So what we like to say is what technologies make sense for whom and when along their care trajectory. And also thinking about the ways that we can use some of these different technologies in a complementary way over the course of the patient's trajectory. I think we are naive in our thinking about implementing one of these technologies. We're trying to get patients to use one technology, which in and of itself is really hard. But what we know is that patients are using a lot of technologies in the course of their lives in self-management. So thinking about models and strategies that really reflect this idea of complementary tech use. And then lastly, we need to keep accumulating our effectiveness evidence base about these technologies. So I'm going to stop there, Ronnie. I want to just say thanks to you again for the chance to join you all, and thanks to everybody for attending. I really appreciate any opportunity we have to share our experiences in the VA to folks who are practicing and doing research outside the VA. It's a chance for us to get feedback and learn from you all as well. So I hope the talk was of interest to everyone, and I think we have at least maybe 5 minutes for questions or so. I'm not sure, but Ronnie, I'll turn it back to you.
That was wonderful, Tim. Thank you so much for sharing that. We have time for at least one question and maybe two. There's someone who put a question into the chat. Thank you, Dr. Hogan, for this important and very informative presentation. My question is this: how long have you typically followed patients and clinicians with technology use after completing a study? And what strategies have you found most useful for sustaining technology use and or preventing disengagement or non-usage attrition?
So, this is a great question, and I think this is a question that is plaguing a lot of patient-facing technology work today. Certainly in the realm of mobile apps, patients engage and they abandon. And I'll use this as an opportunity to do a shout out to one of my mentees, Dr. Jessica Lipschitz, who's faculty at the Brigham and Harvard, and she has a whole cohort kind of thinking about strategies to sustain engagement. The length of time we've followed patients really depends on the kinds of interventions that we have been testing. And so, in some of the texting work we've done, we've designed 30-day protocols. And really, when the protocol ends at 30 days, that's when we've stopped following patients. So we haven't really had that long tail of following folks over time. In terms of strategies to sustain engagement, I'm not really sure. I think the strategies, whatever they may be, are going to need to be highly personalized to the individual patient, and probably need to meet them, early on in their interaction with the technology and at the point of use. And again, I think this is a lot of what, Dr. Lipschitz is thinking about in her K Award, about how do we almost build sustainment messages into technologies themselves, so that that's kind of baked in during the use period, so that we can try to extend and sustain engagement. I don't know, Ronnie, if that's helpful or not.
Yeah, no, that's great. And maybe we can connect this person to Dr. Lipschitz, so that would be fun.
Sure.
It's actually 1 p.m. and we have to end the presentation, but would it be possible for people to contact you if they have others? I know that there's at least one or two other questions that people had. Would that be possible?
Absolutely. No, I'm happy to chat with folks. You can reach me. I'm not sure if my VA email or my UTSouthwestern email is on the slide, but I check both. And so please feel free to reach out. It would be great to be in touch with folks. As I said, I've heard about this community many times from Ronnie, and so I'd love to be connected with you all.
We so appreciate you sharing so much about the intersection of implementation science and informatics, particularly around virtual care. And we really appreciate you being here. Thank you so much for sharing your expertise and time with us. And we look forward to seeing everyone back at our next Friday seminar. So thank you all for being here. And thank you, Dr. Hogan. We're giving you a round of applause virtually.